Good afternoon, everyone. Welcome into another Tuesday and Thursday edition of Care Patrol's educational series. We welcome you in and we thank you for joining us today. There are more people coming into the waiting room, not wedding room. We're not getting married today. And I'm trying to let them in. Those of you who tuned in today and expected to see Jay Jones, I need to let you know that Jay has found a different position that he feels will be a better position for him with a home care provider called Right at Home. And as you may know, those of you who know Jay, that's the area that he came from, was home care. And I think that he's very well suited to help them grow throughout the state and beyond. And we're thankful to Jay for everything that he's done for us in terms of setting up this series. I became aware of Jay some years ago. We were both speaking at different events, and I always enjoyed hearing Jay speak. And he's a brilliant guy, and I only hope to be a shadow of what he did for us. But I am happy to proceed and do these CEUs because I think they're so necessary to the folks who, like you, listen in each week. I know there are some of you who listened in to our last series on Thursday of last week, which was my first attempt at doing this, and I did not do it correctly in terms of the evaluation process. So if you will, just email me, sbarnes@carepatrol.com, and let me know your provider number and the code word from that day, and I will send you a certificate. So my apologies for that, and I hope you'll bear with me as I try and learn to do this as effortlessly as Jay seemed to do it. So we will get into the meat of the presentation as people are joining us. It's a couple of minutes after. Those of you, especially those of you by phone, if you will, please mute your phone. I know sometimes you can get a text message or an alert of some sort and the phone comes off mute. If you'd just be mindful of that, please, so that others who are listening in can fully concentrate. If you have questions, and I hope you have questions, please ask them in the chat room. And I'd love for this to be really something, the chat room, that we all participate in or that you participate in. I don't want these sessions to be just information from a presenter like myself, but really information that you share among each other as professionals who are experienced and have met many of the issues that we'll talk about and can add to the learning of others by sharing your experiences and your stories. So I'm hoping that we will use the chat room in just that way, such that we can, begin to share information and ideas across disciplines, across borders even of states. So thank y'all so much for listening in today. As you may know from past presentations, the Board of Social Work requires that we have at least 40 minutes of content delivered for you to receive a certificate. Therefore, we are not allowing folks to join after 12:20. If you do get knocked off, please shoot me a text or an email. My email again is sbarnes@carepatrol.com, and my cell number that you are welcome to text at any time for any reason is 205-482-8759. Text me, let me know that you're having trouble getting in, and I'll get you back in if I can. But after 12:20, we will not be allowing people to come and join us for today's presentation. The evaluations, which are key to getting certificates when the process works as it was designed to work by Jay Jones and now by me. So the way the process works is that you will get a code word in the midst of this presentation that you are to use with SurveyMonkey. The code word allows you into the survey, and within the survey, you'll be asked your provider numbers and emails and questions about the objectives of today and some comment boxes. So I hope that you will get those done by 5 today so that I can get certificates out by tomorrow. We have digital copies of paper certificates that we will award to both nurses and social workers. This CEU contact hour is actually 1.2 units in nursing and 1.0 in social work. Now, the SurveyMonkey, for those of you on the phone, go ahead and write this down, and we'll mention it again later. But the SurveyMonkey address is https://www.surveymonkey.com/lowercase r uppercase P, uppercase F, uppercase N, 2, uppercase X, uppercase H, uppercase J. We will continue to share this throughout the presentation, but I want those of you on the phone to know that you have some mechanism to show participation. So as we're now into the presentation, let's get started. And just remember that, Care Patrol is a placement agency. We depend on your referrals and would love to help those that either patients, clients, family members who are in need of senior care solutions. We'd love to help, and we're at no charge. We're paid by the providers. You can contact me, Sean Barnes, Dixie Tyler in Decatur, Huntsville, Tracy Talley, who's in Huntsville and Northwest Alabama, and Jennifer Redding, who's in Florence and, Northwest Alabama, and Tracy's in Northeast Alabama. And we're looking to add staff in Birmingham and Montgomery as well. So we, can serve most of the state of Alabama, and certainly are happy to provide guidance to those of you outside our service area. If you want to just give us a call and you have an issue we can talk through, we're happy to do so. Today's lecture, again, is health conditions that mimic dementia. So our objectives today are very simple. We're going to discuss the different types of dementia. We're going to list the early signs or symptoms of dementia, and we're going to detail the various types of MAND, and I'll explain that term a little later. So as we look across the world, someone develops dementia every 3 seconds. So in the time that I've just said that sentence, 1 person has contracted dementia, now 2, 3, 4, 5 persons have contracted dementia just since I started the statement. This number is going to double every 20 years. And while it's increasing in the developed world, it's astronomically increasing in the developing world. And it's due to a host of factors, which we'll investigate today. It's sobering when you think about it. So there are many underlying conditions which could cause symptoms of dementia, which really, as we know, is just a result of changes in the brain. And the loss of nerve cells or the atrophying of nerve cells. So Alzheimer's disease is the most prevalent of the dementias that we will discuss, and of dementias that are present and known. Alzheimer's and vascular dementia, in fact, make up about 80% of known dementia. And they're different in terms of how they affect persons. As you know, Alzheimer's disease tends to be a slower, more progressive, on a flat line kind of decline, whereas vascular dementia can be one that takes sharp dips, plateaus and dips again. So it's, in a way, you can sort of determine on behavior whether someone may have one dementia or another, but truly the only way to know, as you all know, is to do an autopsy. And really at that point, we're not helping that person anymore, but we are helping others. Lewy body with dementia, this could equate for really roughly about 10% of the dementias. And then we have the frontotemporal and the mixed dementia. And mixed dementia is what you would expect. It's persons who may have both symptoms that are unrelated to having dementia, as well as symptoms of one type of dementia and another. For example, the most common would be someone who has Alzheimer's and also has vascular dementia, would be a mixed dementia. And then you would have really a wide swath of symptoms or things that might present in terms of behavior that you would not maybe see as broad a swath in someone who simply had Alzheimer's or simply had vascular dementia. The boundaries are not distinct. We know this, but we know that many of the symptoms are similar across all of these dementias. So early signs and early symptoms, well, I mean, the most obvious would be memory loss, wouldn't it? We know that in declining and short-term memory is what typically goes first, but they may forget other things that are unrelated to short-term memories, but related more to processes that they can no longer accomplish or do. And generally you find that folks with dementia, as it progresses, tend to be able to have greater recall of things that happened in the past, in the distant past, like childhood, versus things that happened today or yesterday or this week. And so, we also find that people with dementia have not only, as I mentioned a moment ago, issues with memory or issues with time and place. For example, many folks with dementia who, by the time they come to me for help, mom or dad wants to go home, and they repeat that they want to go home, even though they are in their home. And so many, clients of ours, families, adult children, are concerned about having their parent in a community for memory care because they're afraid they'll want to go home. And what I have to sort of suggest in a simple or loving way is that home is no longer it no longer ceases to be. Home might even be a feeling that we cannot reconnect. And it may be one that we are connecting, and that the wanting to go home addresses that. But you see people that want to go home, and home is just simply not a place, even though, and this is what is really horrible, they may somehow find their way out of the house or in a car, God forbid, and begin looking for home and get lost. So it's a memory loss, not just of a short term, but I've had people who've been in their home for 10 or 20 years who think they're looking for their home still. So those are some of the things that present most readily, I think, when you have dementia issues with folks. Not always, but most readily. So here we are, admitting more people. Excuse me, y'all. One of the issues we find when we have early symptoms of dementia are language problems. And this is not someone who is forgetting a word, or even someone maybe who's forgetting a name of someone they know, or a neighbor, for example, someone from church. That's not necessarily what we're talking about with problems with language. Yes, that may point to a short-term memory issue, but it doesn't have a language component. The language component would be someone coming to you and saying something using, most often, the nonsensical, made up verbs that sort of hold a place in that thought idea for the person with dementia that really make no sense. It's a nonsensical word. We can follow it, many times, not all the time, but that would be a sense of a problem with language, is not having the facility to know what word to use or what something is called. And remember that really what makes us human in many ways is the ability to name things. If we can name things, we own them in a sense, we control them. And so to lose that capacity to name and to control is part of the demise that happens with dementia and the loss of personality that happens with dementia. And because of this, people who recognize this in themselves, and sadly, most people at this stage in dementia still recognize that something's wrong. They may become more withdrawn because they fear getting in a conversation or in a social situation in which they don't know the words or cannot follow the conversation. So, we all sort of have that moment where we wake up in a panic and we don't know where we are or what time it is or anything of that nature. I remember years ago when I traveled, I used to sell pharmacy benefit management and consulting services to hospices. And I traveled from Florida to Delaware to Ohio to Texas, was gone 2 or 3 weeks a month, which is why I got into Care Patrol actually. But when I traveled, it would happen to me more often than I'd like to admit that I would wake up in a hotel room and not know what city I was in, where I was, what time it was, who I was. Sometimes I might have had an hour or 2 sleep after driving from the previous day's meeting. So we all have that. In fact, we all, I think, have those moments when we think, oh my goodness, I hope I don't have dementia, because we have some lapse, forgetting a word or losing our keys or not knowing what hotel room we're waking up in. But folks with dementia are much more prolific with them. So they can get lost on the road they live on. Okay. Or, they can get lost in virtually any situation because they have no concept of place nor where they come from because they have no memory of it. And many times we find that people with dementia even confuse day and night. We see this a lot in communities that serve memory care patients, is they will have very exhaustive activity calendars for during the day. And the idea is to keep folks alert, awake, and doing something so that when night comes, they naturally fall asleep versus being awake all night and wondering. Now, it's not a problem in a memory community if they wonder, but it's a problem for the individual. If they're not getting appropriate proper sleep, they're further diminishing their capacity to think and to reason, which is already diminished. So we see in many folks who have dementia poor or decreased judgment. Now, this was something for me that was really eye-opening. And it was my own family. It was my own mother, in fact, who really, to me, presented none of the symptoms we've just discussed, for example, of dementia. So she had no loss of words, no loss of short-term memory. She could still plan, organize, pay bills, do her finances, organize her home, have workers come in, fully functioning, independent 82-year-old woman who one day received a call from the Publishers Clearinghouse. You may know this story, some of you, I hope not. Waiting for, she was called and said that she won $3.2 million, and there were just a few things they had to handle first. And one of those, of course, she had to pay taxes, as you would expect, before she got her money. And the other thing is she had to pay lawyers, because clearly, why wouldn't you pay their lawyers when you're giving them money? So my mother believed all of this. It was plausible to her. And I think in her, there was something almost childlike about winning this money. And this is how I came to realize that my mother had dementia, because she had judgment issues. Because even after she sent gobs of money and things like, shoes to various people to pay for her lawyers and taxes, she would not listen to me. She would not listen to anyone. She would not listen to the judge who gave me conservatorship. She believed that she had won this money, and she was convinced of it. And there was no telling her that she didn't. And this was when I realized my mother had lost the capacity of judgment. She had lost the capacity to size up cause and effect, to recognize something that wasn't quite right and say, no more, I'm not going to participate in this. I understand many elderly folks get duped once. My mother was duped over months before I found out, and I only found out because the bank called me. So that's just a story, I'm sorry, a personal aside about decreased judgment and how that can be present with dementia. But again, astonishingly to me, present with no other symptoms of dementia. And so that's, I think, what's so insidious about the disease, or the series of diseases, is that we sometimes don't know or don't find out until it's almost, or until it is too late. Problems with concentration, planning, and organizing. You see a lot of the times folks that are aged, that have dementia, who've, if you go into their home, which I do to assess them, you have to cut a sort of path between boxes and magazines and cat toys and old furniture and old walkers and extension cords across the floor. We discussed this last week, home safety, but people with dementia maybe find it difficult to know what to get rid of, so they just become almost by default hoarders. And they don't solve this issue. They do nothing about it. They withdraw, they hibernate. Misplacing things, this, I think, is when most of us who don't have dementia would say, oh my gosh, do I have dementia? Would be when we misplace our keys, or my wife who misplaces her phone. And she has two phones and she misplaces them both daily. But nonetheless, she doesn't have dementia. She just misplaces her phone. She has other things on her mind. Life is full of distractions, and the phone gets placed down. What would be concerning would be if she put the phone in the dishwasher, thinking that's how it worked. That is dementia. Okay. Dementia is not losing something. Dementia is using that thing in a way that it wasn't intended, like using your keys to start the television. This is dementia. It's not simply misplacing things, it's the use of things that are not really intended to be used in that way. And then so often we see that folks with dementia have depression. And we will see later in today's talk that depression actually mimics dementia in many ways and sometimes disguises it. But we do want to look out for folks who have rapid mood swings. This is most telling in terms of a dementia diagnosis. Certainly, depression is part of that, but elation would be a part of that as well, and a hyperactivity would be part of that. So a going back and forth would be something that would let us know that, hey, there's something amiss here. I think I've skipped a slide. Yes, trouble with spatial relationships. I'm sure that many, if not all of you, as social workers and nurses, have seen or administered a mental exam of some sort. And you all know that if you've done that, there are a couple of questions on there that relate to spatial issues, such as drawing a triangle, a circle, and square, or drawing a clock face. And so people that have dementia can lose the understanding of how those things relate or what they mean. And they also have difficulty with just judging distance and depth perception and seeing objects in 3 dimensions. So again, back to what you might see in a memory care community. Generally, of course, you'll see a handrail, but usually beneath that handrail, you'll have a different color, usually a darker color, wall color. And then above that handrail, a lighter color. And this gives us some sense of greater contrast, greater color variation, so that we can begin to see somewhat spatially where we belong, where the handrail is, and also by having the floor in a different color or pattern gives us more awareness of where to put our feet next. So we find that same thing that we may get around someone's issues with spatial ability or awareness or movement. We can also help them increase their appetite by doing something like changing the color of the tablecloth from white to name a color, red, blue, yellow, green, and then having the plate perhaps be a different color, white. Someone's waiting, let me let her in. So you might have a white plate and then colored food. So when people with dementia can see their food, because it's not the same color as the plate, not the same color as the table, then they tend to eat more. And so again, we're using a spatial and a color enhancement to get someone to do the task that we want them to do. But again, we want to have a lot of activities in a community, or if you're caring for someone at home, you want to try and do that as well as best you can, have outings and activities, puzzles, things to keep someone engaged, to keep their mind active, because what you'll see happen most often with most everyone who has dementia is that they withdraw. They become socially isolated, and this further worsens their dementia because they're not being stimulated, because they don't have social interaction, because their mind is not kept alive and plastic by new things, new sensations, because they withdraw, they watch television, they sit in their chair, and the world gets smaller and smaller and darker and darker and smaller until generally a crisis happens. So what we want to discuss now is our CEU code word, which is the acronym for major neurocognitive disorders. And the acronym is uppercase M, lowercase a, uppercase N, uppercase D. So that's, I think, would spell manned, but I don't know if it's pronounced that way. I haven't seen a pronunciation for it. But in general, the DSM-5, are y'all familiar with the DSM-5? I know some of you work in mental health, but it's the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, which was released in 2013. The term major neurocognitive disorder has now replaced, at least in the medical journals, clinically, has replaced the term dementia. So MAND is the new dementia. And as you would expect, this could encompass not only Alzheimer's and vascular and other sort of obvious dementias, but a whole host of other issues that relate to the biological issue with the way the brain is functioning, which affects the cognition, which is the ability of the brain to think, to reason, to judge, to move in some cases. Let's see, I have another person waiting, but it is after 12:20, so I'm sorry, she will have to wait. And y'all, excuse me, I know that's harsh not to let someone in, but we do have to follow the Board of Social Work and allow folks to get their full 40 minutes so that they're satisfying what the board wants them to satisfy. So MAND is our CEU code word, and we'll get to that later, but essentially it's a neurocognitive disorder. Let me get my screen going again. And we're going to discuss these, although major neurocognitive disorders are certainly not limited to these 9 that we've listed here and that we'll discuss in greater detail momentarily. But there are other things that may present temporarily with issues that we would confuse with dementia that in fact could be curable and reversible. And one such is B12 deficiency. And I think it's something like 20% of folks over 65 have a B12 deficiency. And I read a few different case studies of folks in that age bracket who presented and were given a diagnosis of dementia as primary, but who were discovered to, have a B12 deficiency on the labs that were run, so that with some antibiotics and some therapy, or not therapy, but B12 injections, then these people returned to normal. To beyond base where they were before. So B12 is one of those things that, while it affects a large swath of people, it's not a major neurocognitive disorder, but it is certainly something to be aware of and something to have eyes on when you have someone presenting who appears to have dementia. Depression, we'll discuss depression a little later in this, but as you know, depression affects someone's energy level typically, and people who are depressed to withdraw and isolate. They tend to lose pleasure in daily activities, and these are all symptoms that you might see in an elderly person and mistake is dementia, when in fact they may be depressed. Now, depression and dementia run hand in hand, as you know. So certainly folks who have dementia have depression. So ruling in depression doesn't necessarily rule out dementia, but it's certainly something to be aware of. And then there are all sorts of medications that are contraindicated for dementia or for the elderly. And we'll discuss those as well. And yeah, Darla, I see, thank you, Monique, for posting the code word for today, MAND. And Darla, yes, to answer your question, we'll send out this presentation at the close, along with your certificate, once you've been to SurveyMonkey and done your evaluation by 5 o'clock today. So head trauma is one of the major causes, certainly for younger folks, of an acquired brain injury, of a dementia, so to speak. And it's because of the trauma that happens to the brain. So there may be, something like a bleed inside the skull that causes a hematoma, which can either put pressure on the brain or put pressure on the vessels leading to the brain, to the extent that maybe that part of the brain atrophies or dies. And then we begin to see, depending on where the injury occurred, all sorts of things that may have motor problems or issues with following directions, issues with being able to understand complex procedures. All of these things that sort of mimic and mirror dementia are not dementia, but are part of the new over sort of word for dementia, which is a major neurocognitive disorder. And I'm sure that there are some of those of you who see this in your clinics, in your practice. This is interesting to me, and one of which I was not really aware until I did some research: normal pressure hydrocephalus. And so let's see. It says here that 10% possibly of dementias are of the normal pressure hydrocephalus variety. And this is when cerebral spinal fluid gets into the brain cavity and enlarges, and much like a traumatic brain injury, causes either the vessels to contract or to sort of decline or atrophy in the brain. But it has a lot of things. It affects not just those cognition issues, but also things such as incontinent issues, gait and posture are affected. Speech is affected typically with folks who have normal pressure hydrocephalus. And it is often undiagnosed or thought to be Alzheimer's or vascular because they're more prevalent dementias, or even sometimes might be confused with a Lewy body dementia because of the issues with motor skills. There are problems with vision and hearing that can either A, mirror dementia, or B, exacerbate it. And sensory limitations are a natural part of dementia as it progresses. We've discussed already how vision and the sense of spatial things and three-dimensional things can be lost with dementia. We also know that hearing can be lost. And again, this is where we sometimes maybe misdiagnose someone who has a hearing issue who just simply isn't able to answer the questions on the mental exam, or you have someone that's just simply incapable, but it's not because they have dementia. Although there is new research that shows that a loss of hearing can be a factor in someone getting dementia or cognitive impairment, one of these major neurological impairments. Excuse me. Disorders of the hearts and lungs. Well, this may ring true to you if you get the understanding how traumatic brain injury or hydrocephalus can affect someone in having dementia or having dementia-like symptoms, whether it's an inability to find a word, or a shuffling gait, or a lack of control of the bowel. These are all things that sort of originate obviously in the brain. And when you have heart disorders, you have less oxygen going to the brain, it atrophies. Generally, you find that people that have heart disorders have vascular dementia. Now, I think we mentioned earlier that you may have mixed dementia. So you may have someone that has Alzheimer's that also has hypertension who develops vascular dementia on top of the Alzheimer's. But generally, when you look at someone that has this vascular dementia, you see that they generally have about a 3-year expectancy of life after, and this would be people that develop vascular dementia after stroke, which is what is most common. When you have heart issues, they lead to stroke. Stroke leads to dementia. And it's usually, again, vascular dementia, which is huge, precipitous changes generally in personality. You may have someone who was always put together who now has no interest in their appearance. You may have someone who was a deacon in their church who now cusses like a sailor. Vascular dementia is just great swings in personality and behavior, more so than Alzheimer's would typically present. And then liver and kidney disease would affect in the same way heart and lung. It's affecting the processing of toxins in the liver and kidney that then send toxins to the brain that then affect in a dementia type setting. Now, the thing with folks with liver and kidney failure and disease is those dementias are not curable or really even treatable. You can treat the symptoms, but folks that develop those types of dementia have no hope of return, unlike someone maybe that has a B12 deficiency. And it can result in metabolic encephalopathies, which again are cause chemicals in the brain to affect the brain's cognitive ability. Is the best way I can put it as a non-clinician. And then there's hormone disruption. And I know that there may be folks on this call who recognize, the changes in hormone levels in the body at a certain age. And how this can affect you in terms of your mood, lethargy, pain. These are all things that would mimic dementia for someone, in the sense that they would have, the MAND-like symptoms, and anything that's in the thyroid, which controls brain chemical function, is going to have, cause a forgetfulness, so to speak, brain fog that you might expect someone to have who had full-blown dementia. Now, the hormone disruptions, again, are ones that are not, again, they're ones that can be treatable, like B12. So, and here's our CEU code word one more time. I think Monique Williams has put it into the chat room, but those of you listening, the code word is uppercase M, lowercase a, uppercase N, uppercase D. And I can only guess that that spells manned, but I haven't heard it pronounced. But it stands for major neurocognitive disorder. Infections. This was really enlightening, learning more about Lyme disease and its progression. And you know, you hear more about it. I was reading an article just the other day that the ticks that cause Lyme disease are moving now into the interior of Maine, and then which is they think they'll move then south. And so they're moving away from the coast into warm areas now that were once not habitable for them. But folks that have Lyme disease have a horrible, horrible time of it. And what may be worse is that over time, their brains are damaged in such a way that they develop dementia as well. We probably know the gangsters and the history, you know, Alexander the Great, Al Capone. There have been many folks through history for whom syphilis has caused cognitive dysfunction. And so any number of, you know, viruses or diseases can do this. But then there are short-term functions like UTIs that are frightening to witness that are not considered major neurocognitive disorders because they're short-term, because they're treatable and curable. But it is very difficult, as you probably know, to talk to a family member whose loved one has had or is having a UTI. You sort of have to really lovingly tell them, I know this looks bad, but it is going to get better. Give it 24 hours, 48 hours, will be fine. But, you know, when people are trying to escape the hospital and whatever, you know, you've been there, you've seen it. It's a frightening thing, but that pneumonia, other infections, these can cause erratic behaviors, aggressive behaviors, but they don't necessarily signal dementia, nor do they in any way, as far as we know, lead to dementia. And then there are cancers, which one that sort of got me, that I found most interesting was the paraneoplastic syndrome. This is another dementia that is related to disease that attacks a small percent of the population, but is uncurable and untreatable. And it is those persons who have cancers of tumors on the brain because of the swelling, all of the reasons we've discussed prior, the contraction of vessels, the swelling, the pressure will cause them to have dementia-like symptoms, slurred speech, vertigo, many of the same sort of symptoms that you might see with Parkinson's, you know, that deal with attention and memory and, you know, wandering, hoarding, delusions. All of these things can be a part of this cancer. Oh, Clarissa, thank you for speaking. And again, I want for this to be a forum where each of you feels comfortable chatting in the room, not only, you know, to enrich me and what I'm saying to you all, but to enrich one another. I hope that we can use these chat rooms as a way to share expertise across disciplines so that you all benefit not only from the teaching of the day that's presented by Care Patrol, but the teaching that you receive from your colleagues in care. So cancers, or some cancers, brain cancer leads to paraneoplastic syndrome, which is so distressing, really, to think for those folks. And then there are toxic metals. So these would be folks that have been exposed to or ingested lead, for example, or other chemicals over a long period of time which can lead to encephalopathy and dementia. So a swelling of the brain and a causing of that, and that causing dementia type symptoms. So toxic metals, I think we will see less of this type of dementia as these age cohorts age out, and the safety precautions of the last 50 or 60 years begin to take root. But toxic metals can certainly be an issue of concern for dementia, and again, is not reversible. And then there are other toxins that are more readily available that might be not ingested over a long time, but a short time. And encephalopathy in anyone, whether it's due to Lyme disease or tumor or trauma, is going to have a negative effect on the brain. It is likely going to atrophy kill some of the cells in the area that's affected. And alcohol is certainly known to do this. We find really many times that when we have folks that have a dementia related to liver cirrhosis, it is because they were and or are alcoholics. And not only does it damage the body in general and the brain and the mind, in my estimation, but when it affects the liver, then the toxins that the liver is supposed to fish out end up in the bloodstream and in the brain. And this is the issue. Psychotropic drugs. We've seen over time how use of drugs, marijuana, LSD, other things has affected folks in such a way that they lose the ability to live in the reality that we live in. And while I don't know that that is necessarily dementia, it certainly could be the precursor, or that could be an outcome of it. And then there are any number of other things that people ingest around the world, like SIAD, that can cause neurodegenerative disorders. There's probably every society, certainly every indigenous society, probably has some sort of pill, seed, powder, herb, fungus that causes a excited mental state that, if abused, which it would be in the West, would have a deleterious effect on someone over time. And then there's vitamin deficiency. We've talked a little bit already about vitamin B12. It can be reversed, unlike Alzheimer's, but it mirrors those symptoms. So while we have 6.2 million folks in the US with Alzheimer's, and it's the 6th leading cause of death, we have 20% of people over 65 who have B12 deficiency. They do not have dementia. Although there are studies that link B12 to Alzheimer's, or at least the lack of B12. And it can even cause, according to some reports, atrophy, shrinkage of the brain, like Alzheimer's. And then there's depression and dementia, which are really intertwined. I find that most every elderly client with whom I work is depressed. I know it from the flat affect on their face. I know it from the lack of enthusiasm that they have. I know it from the way that they walk slowly and purposelessly. But all of those things that I've just said could be signs of dementia or mimic dementia. People who are depressed withdraw. We talked about this earlier. People who have dementia withdraw. And so again, maybe hard for us to see which of these are we suffering. Isolation, though, I can tell you, is the worst thing for both people, both those who have depression and those who have dementia, because it further exacerbates the very things that cause them distress. Depression, they say, doubles the risk for you down the road of having dementia. And then if you have a high blood pressure diagnosis, you triple the risk. So I sit here to you today and I tell you, I am a triple threat risk. So I may have dementia. I do not yet, unless you've seen from what we've pointed out that some of the symptoms I'm exhibiting, but I think not. So the I have trouble with this word, y'all, anticholinergic drugs. There is, without question, an absolute one-to-one relationship between these antihistamines and others that cause dementia. They should never be prescribed for someone who already has dementia, and they should not be prescribed for persons who are over 65. Nonetheless, they are. But we need to avoid those if we have someone who's taking them, including NSAIDs, which are not anticholinergic. You know what I mean? These can be deleterious to folks, as the benzos are used to treat, and the anticholinergic are used to, well, not used to, they cause issues for us. And then we look at the antidepressants. Y'all may know this. This is probably more information about depression than you thought you were getting. There are different classes. The tricyclics and the MAOIs are the ones that have been around forever, since the 50s or mid-century of last year. The SNRIs are the newest ones, and those and the SSRIs reuptake inhibitors. So they regulate your endorphins. I think I'm right about that, but those of you who are in mental health, correct me. Here are the opiates and NSAIDs. So I don't know how many of you know folks like I know who, take on a regular basis a Tylenol. I don't know that there's anything worse you could do for yourself than take on a regular basis a Tylenol if you wish to avoid dementia. Certainly if you're my age, I'm 54. So, I avoid them, and I definitely think we should avoid them for the elderly. And we know that they will lead to complications for the elderly. We know that they can lead to dementia-like symptoms. And then there was a study that was recently done about people using opiates. And as we know, this is a problem that is all over our country and world, perhaps. But opiate abuse is definitely 20% of the folks that they studied who used opiates on a regular basis developed dementia. 20%. It's amazing. So that is the end of today's presentation. Again, the CEU code word is M. It's an uppercase M, lowercase a, uppercase N, uppercase D, MAND. You'll get that at SurveyMonkey. So if you're on the phone, please have a pen ready. I'm going to give you the address for SurveyMonkey, and maybe someone will be kind enough to put it in the chat room for those who are online. It's https://www.surveymonkey.com/lowercase r/ all uppercase PFN2XHJ. So please today go to SurveyMonkey, put in the CEU code word, leave your email, your provider numbers, answer the evaluation, and I'll get your certificates to you by tomorrow. If there's any questions, please email me. My email is here. It's sbarnes@carepatrol.com. I hope this has been a helpful use of your hour. I hope that if it has not affected you in a professional basis because you either don't work with the elderly or those with dementia, I hope if we haven't been able to reach you on a professional basis, that we've been able to enrich you on a personal basis, perhaps some situation you have at home in your own life with your own family. Thank you, Darla, for posting that for everyone. Thank you all for listening in. I hope you'll continue to listen in as I get my feet under me and doing these on Tuesdays and Thursdays moving forward. Look for Jay and his new company. They'll be doing stuff soon as well. And I know that he and I are always happy to provide a service to you all who provide a service to so many. Christine, I see your message. You did not get a certificate. Please email me. at sbarnes@carepatrol.com, and I will send you a certificate. Just email me with your provider number, please. Or if you go to the website where we register for these weekly, you'll see that the same instructions are there. I apologize for my inability to get to doing this properly the first time around, but we're getting better, and we appreciate you listening in and giving us the opportunity. Okay, someone did not ask for a code word, but you were able to complete the survey. So once again, I've maybe made a mistake in how we do this, but it is working, I see, I hope. If not, again, please email me, sbarnes@carepatrol.com. It did work. Thank you, Kristen. Thank you so much. Thank you all for listening in. And please share with me in email or other ways topics that you'd like to hear us discuss and research, or topics that you'd like us to find someone who's a true expert to share with you. I'd love to be able to bring you folks from all sorts of backgrounds who meet your needs across whatever spectrum of healthcare you address. So as we're winding down the hour, again, I'll tell you that Care Patrol is a placement agency. We refer, yes, ABN license number, please, Michelle, is what that means. Yes, ma'am. I'm sorry for the confusion. If you will think of us, if you do work with the elderly or with, generally patients that are 62 or older who may need help in just understanding what's coming, we can sit and help them create a plan for no charge, or we can execute that plan all the way through to landing them with a provider. And throughout that process, we are at no charge. So I hope you'll think of us when it comes to in-home care referrals or assisted living or memory care. And certainly we can help you if you're looking for a rehab or nursing home. We can help there as well, although that's not how we're paid. But we certainly are wanting to help you in whatever way that we can, whether it's in Huntsville, Birmingham, Montgomery, or in other states. You may be in Atlanta. You may be in Jackson, Mississippi. You may be in Nashville. We have Care Patrol offices in all of those places, except Mississippi, unfortunately. But we can certainly help you there through your local office. So please remember Care Patrol as you come across folks who are in need. Thank you, Darla, so much. Thank you all for listening in. I look forward to seeing you all, I hope, on Thursday, as I think we discussed dementia in the ED. So that should be interesting. And again, if you have stories or anything you'd like to share, just shoot me an email or a text before the presentation and we'll work it in. Here's a question, and let me read it. Sean, I was wondering if you could talk about how dementia interacts with other events or disorders that impact neurocognitive effects. For example, if someone has a stroke, some of the symptoms of dementia could follow a stroke. Is it worth distinguishing whether the symptoms are a result of dementia or simply follow a stroke? Is it possible, meaningful, or relevant? Brian, I love that question. You may be above my pay grade, but what I would suggest is that it may be a moot point, because whether they're exhibiting those symptoms due to stroke or due to the onset of dementia, we want to address those symptoms in the short term, If it is dementia that they're developing, there's very little that we can do other than maybe slow the progression through certain drugs that we could administer. But I can't see that we would want to treat the dementia as primary over the stroke issue. I'm not sure if that is the question you were asking, but it's my best attempt at an answer. But if it's not a suitable answer, let me ask, and I will get you an answer, Brian, if I haven't answered your question. And that's one thing that we do try to do as Care Patrol, is we don't have all the answers, but we have a pretty broad network, and we'll find you the answer if you need it. So give us your questions and let us help you. And thank you again for tuning in today. I appreciate you all so much. And I'm humbled by what you do for others, the service spirit that you have. And I encourage you to keep going on. The CEU code, Angela, is apparently not turned on. So if you're trying to use the CE code word manned, which I went to so much effort to try and establish. It's not working, and that's my fault. But just if you will complete the survey anyway, I appreciate it. I'm going to end our share now unless there are more questions. Thank you so much for listening in. Again, thank you for what you do, and please continue to listen in. Have a great afternoon and a great week.